Start, ma'am.
Good afternoon, everyone. I am Dr. Malleshwari, glaucoma consultant, Sankara Eye Hospital, Guntur. Today, my topic is glaucoma and systemic arrays. So, this is for the awareness of the glaucoma week. So, this year we are conducting glaucoma week from March 12th to March 18th. So, today I am going to explain some systemic arrays in glaucoma patients. So, previously, glaucoma is defined as chronic progressive optic neuropathy, which was caused by the elevated intraocular pressure. But the current definition is the damage may be caused by either raised IOP or sometimes in some patients the normal IOP also. So the current definition of glaucoma is not merely depends on the presence of the elevated intraocular pressure. So the definition of glaucoma evolved through years. Like it may be because of raised intraocular pressure or maybe a normal intraocular pressure which can cause damage for that patient. So whenever you see a glaucoma patient or some patient is referred to you for glaucoma opinion, so we have a suspicion whether it is really a glaucoma case or not. So what are the things we need to consider when you want to decide whether it's a glaucoma patient or not? So one is the presence of the pale disc. So if only paleness of the disc is there, then we need to consider it a neurological cause or some other secondary optic atrophy. And if the visual field is obeying the vertical meridian, then it mostly goes in favor of neurological causes. So if the intraocular pressure, whether it is raised or not, the raise may be transient or the raise may be because of some other pathology. So we need to rule out whether that raise can cause damage to the optic nerve. So these things we need to keep in mind whether we need to label the patient as truly glaucoma patient or not. So in few patients, they are on anti-glaucoma medication, the pressures are well controlled, they are within normal range and they reach their target pressures which was defined for that patient. So in those patients also we found some progression in visual field. So is that well-controlled intraocular pressure for that patient is actually well-controlled is the question of our today. So we are going to tackle with these type of patients. So sometimes we may come across with disc like this. So it is having a large wedge-shaped RNFL defect and a disc hemorrhage inferiorly, inferiotemporally. So this disc is giving us the clue that the disc is at risk. So the disc is telling us like I am at risk, I may go into progression. So these patients we need to consider what is the pathology behind this disc hemorrhage and what is the pathology behind progression in spite of normal intraocular pressure or well-controlled intraocular pressure. So similarly, we have one patient which whom we saw in 2016. So he had very nice RNFL defect which was depicted in the picture and with a disc hemorrhage. And the pressures were normal 17 and 17 in both eyes. But this patient, we diagnosed him as normal tension glaucoma patient. We advised anti-glaucoma medication and asked for visual field examination. But patient lost to follow because he stays in abroad. So he came after 4 years. And after 4 years in 2020, he came and his VOCT was showing like this. And from 2020 to 2022, he used to come to the hospital regularly for every 8 to 10 months. And he is taking medication, anti-glaucoma medication. Pressures were around 16 to 18 millimeters of mercury. In spite of all these things, his OCT was progressed from 2022 from 2022. So this inferior RNFL loss was there from 73 microns to 62 microns in right eye. So on the visual fields 10-2, this is 2022 visual field which was showing a mean deviation and which was increased in 2022. So this is also showing progression. In spite of having very good control of intraocular pressure, this patient is progressed. So what are the reasons behind this progression? So in these type of patients, what we need to see? So what are the various studies were saying? So according to OHTA study, ocular hypertension treatment study, 5% of the subjects developed glaucoma despite of 20% reduction in the baseline intraocular pressure. And according to CNTGS study, The disease progression was occurred in 12% of the patient despite 30% reduction in the baseline intraocular pressure. According to EMGT study, there is a 45% progression of the disease in case of patients and EMGT study, although there is a reduction of the average of 25% of the intraocular pressure from the baseline. So in all these patients, we need to come from the beginning, from the top. So from the history taking itself, we need to consider the examining the patient again and again. So in the history, we need to ask for the occupation, because the intraocular pressure, the office of measurement of the intraocular pressure was under well control, and the patient still progressing. So we need to ask for the occupation, whether the patient is a weight trainer or a weightlifter, or if the patient is having an occupation of wind blowing instruments, or if the patient is a yoga teacher or practicing yoga every time. And all these things we need to ask in the occupation, because these are the some occupations, those patients who are going to progress despite the well-controlled intraocular pressure. And second one is the general habits. Intake of coffee and alcohol, we used to ask in the general examination during our MBBS days. But here also it is important, because in moderate amount, if you take coffee and alcohol, that can cause little decrease in the intraocular pressure. But in case if you take more large quantities, then this can cause raise in the intraocular pressure due to fluid overload. And the next thing is the diabetes and hypertension. In our case history, we used to note down diabetes, hypertension, COPD, and heart ailments. All these things we will regularly ask each and every patient. COPD and heart diseases comes under the treatment of glaucoma patients, because beta blockers are contraindicated, and heart patients beta blockers are contraindicated. So these patients, if the diabetes and hypertension is not controlled, again they are going to progress in their glaucoma stages. And the next one is the migraine and the sleep apnea and excess sweating or any hemodynamic influences on the patient. So the patient, previously I showed you, the patient works in Nigeria. He used to drench a lot when he goes outside. So he had the episodes of excessive sweating and loss of consciousness 5 times. And so maybe that may be the reason, because the patient was taking very compliant to the medication, and he is following with us regularly, but still his visual fields are progressing. And if you see these type of patients, when the pressure is under well control, what are the next things we need to do? So we have so many questions in mind, what we need to do, what tests we need to do. So these are the few considerations. One is the diurnal variation. We need to repeat the diurnal variation. If the variation is more than 8 millimeters of mercury, we need to reduce those fluctuations by giving a long-acting agent or by doing surgery. And second thing is we need to repeat the gonio also. Sometimes we may miss out a few early angle closures with the synechia. So we need to do repeat gonio for these patients. And in the history, again, we need to ask for the migraine or any vasospasms and nocturnal hypotension. If the patient is hypertensive, if the patient is using nighttime dose of antihypertensive medication, which can cause nocturnal dipping of the diastolic pressure, which reduces the ocular perfusion pressure, again causing progression of glaucoma. So this thing we need to keep in mind, not only in normal tension glaucoma patients, but all patients who are progressing despite of well-controlled intraocular pressure. The next thing is the hemodynamic problems like excess drenching of sweat or acute blood loss can cause progression of glaucoma. And sleep apnea patients, they used to progress because there is a hypoxic episodes which can cause spasm and decrease blood supply to the optic nerve. And the final thing is any neurological elements which can mimic glaucoma or which can exacerbate the underlying glaucoma. So these things we need to consider for the patients who are progressed despite of well-controlled intraocular pressure. So other factors which we need to see in these patients. One is the posture or sleep position. Sometimes if the patient is having bilateral glaucoma but progressing in one eye. So if you ask for the sleep position, sometimes those patients, they used to sleep in one particular position, which can cause raised jugular venous pressure and progression of glaucoma. So the next thing is excess fluid intake at a time. Nowadays, the theory is if you take excess fluids or excess water at a time, that can cleanse your kidneys. So this is not true for each and every patient. Out of 100 patients, 2 or 3 patients, it can cause raised intraocular pressure. But it may be there for some days, or sometimes in few hours the pressure will come down. But when the pressure is elevated, that can cause damage. So this is nothing but a positive water drinking test. So if the patient is progressing despite well-controlled intraocular pressure, we need to ask for this habit of excess water intake, especially early in the morning. And the next thing is the fluctuations in the blood pressure. So if the blood pressure is fluctuating, that can cause vascular dysregulation, and that can leads to the progression of glaucoma. And the next thing is the Valsalva maneuvers or blowing wind instruments. Some patients, they used to blow the wind instruments. Maybe it is their occupation, or the weightlifters or weight trainers, or those who practice exercise by weightlifting and all. So these causes raised intraocular pressure and progression of glaucoma. And one strange thing is yoga. Yoga can also cause a progression of glaucoma. I am having one patient. He is actually a defense patient, defense armed force patient. He used to do yoga regularly, and he used to do Sirsasana and Sahasrasana every day. So he lost one eye because of glaucoma, and other eye also 0.9 cupping. So these tilted postures, total head down and legs up positions, they can cause raised intraocular pressure and loss of vision because of glaucoma. And if a fit patient comes to you with glaucoma, you need to ask their exercise pattern. If the patient is doing aerobic exercises, then that is good for them. If the patient is doing yoga, that is also good for them. But the thing is, we need to avoid these inverted postures in those patients. And the next thing is coffee and alcohol. As I already explained, in moderate amounts, they can reduce the intraocular pressure by 1 to 2 millimeters of mercury. But if you take in larger quantities, that can cause fluid overload and the rise of intraocular pressure. And the next one is the using of neck collars. So because of lifestyle diseases or spondylitis, the patients were advised to use the neck collar 1 or 2 hours per day, or sometimes while traveling. But as a caution, patient used to use the neck collar every single hour when they wake up. So that can cause pressure over the jugulars and rise in intraocular pressure. I have one patient similar with this similar problem. So she is actually having spondylitis. She used to wear this neck collar all the time. Her fields were progressing every time whenever she comes for follow. So when I went back and asking for any use of neck collar, she was telling she had spondylitis and she used to use it in home always. So we need to explain the patient about the neck collar, and whenever the doctor prescribe them, they need to use that one for that particular time, not for the whole day. And the other comorbidities which are associated with glaucoma, like systemic hypertension, diabetes, aging, migraine, and sleep apnea. I will explain little in detail about these things. So there is always autoregulation in the every tissue in response to the change in the perfusion pressure. So if this autoregulation, likewise, even in the eye also there is a autoregulation mechanism which regulates the blood flow to the optic nerve head. And if it is deranged by various mechanisms like raised intraocular pressure or fluctuating blood pressure or an increasing tissue demand, this can cause change in the blood flow, which resulted in impaired autoregulation. Finally, this leads to the ischemic damage to the retinal ganglion cells, and RGC cell death finally leads to glaucoma. So this is the normal mechanism, and how the systemic hypertension will get affected with this. So diabetes and hypertension both are microangiopathies. So if the BP fluctuates, there is a decrease in the ocular perfusion pressure, which can cause dysregulation in the vascular autoregulation, which impairs the ocular blood flow and loss of ganglion cells. Sometimes if the patient is not taking proper medication, that can cause uncontrolled hypertension, which leads to the vein occlusions and painful blind eye because of neovascular glaucoma. And if the patient is taking antihypertensive medications very regularly, especially during night time. That patient can have nocturnal dipping things like the pressure, the diastolic pressure will dip in the night times. That can cause reduction in the ocular perfusion pressure, finally leads to the ischemic damage to the optic nerve head. And some concentrations for the antihypertensive treatments also. The beta blockers, if you give systemic formulations of beta blocker, that will mask the effect of the topical beta blockers. So whenever you want to prescribe topical beta blockers, if the patient is hypertensive, whether they are using beta blockers or not, we need to consider that one also. And the calcium channel blockers in topical formulations, they will increase the blood supply to the optic nerve head because of vasodilatation. But in systemic formulations, in some studies, they showed that the POAG, the chances of the incidence and the prevalence of POAG is more in patients who are on systemic calcium channel blockers. And ACE inhibitors, again, they will increase the optic nerve head perfusion, and that can cause some protective effect on the optic nerve head. So presence of systemic hypertension is an independent risk factor for glaucoma progression. So the next one is the diabetes. Again, it's a microangiopathy. So it causes vascular dysregulation and optic neuropathy. If the diabetes is not under well control, it can lead to proliferative diabetic retinopathy and finally leads to neovascular glaucoma. Again, is a painful condition. And the aging can affect glaucoma. Glaucoma is an age-related disease. After 40 years, the incidence of glaucoma will increase. And after 60 years, the incidence of glaucoma is more when compared to 40 years. So with aging, there is a progressive decrease in the thickness of the choroidal complex. So this density is around 200 microns at birth and 80 microns at 90 years. This choricapillary density will decrease and the lumen of the diameter decreases, which increases the resistivity of the resistivity index at the retrobulbar vessels. This decreases the ophthalmic arterial endodiastolic velocity, which finally leads to vascular damage. And the migraine, association of migraine with glaucoma. This migraine is associated with elevated levels of endothelin 1s. This endothelin 1 can cause vasoconstriction, which can cause vasospasms. It disturbs the vascular autoregulation and causing vascular damage. So according to CNGTS study, migraine is a potential risk factor for glaucoma, as well as it is emerged as an independent risk factor for progression of glaucoma. So the final one is the sleep apnea. So what is sleep apnea? Sleep apnea is the obstruction to the airway with soft palate or with the tongue at pharyngeal level. So if it is more than 10 seconds of loss of breath, that is called as apnea. So this can be measured by apnea hypopnea index. If it is AHA less than 5, that is normal. If it is 5 to 15, that is mild. If it is between 15 to 30, moderate, and more than 30 is severe. There is one study done by Dr. Manoj et al. In Amrita Eye Institute. More of the sleep apnea patients are associated with glaucoma. That comes around 29%. So what is the mechanism in sleep apnea? Sleep apnea can cause hypoxia and vasospasm, which leads to the hypoperfusion and the vascular damage. This vascular damage again causes a secondary indirect damage because of the toxin release. So this sleep apnea is associated with normal tension glaucoma as well as progression despite of the well-controlled intraocular pressure. So in treatment of glaucoma, our aim is previously only to reduce the intraocular pressure, and the newer guidelines are it is not only to lower the intraocular pressure, it is to decrease the intraocular pressure fluctuations and increase the vascular blood supply to the optic nerve head and neuroprotection. So all these systemic conditions, if you taken into account in a patient who are under well control with the help of anti-glaucoma medication, still if they are progressing, we need to consider all these things and we need to treat the patient as a whole. Thank you for patient listening, and thank you SAV for giving me this opportunity.